going to do these 2 implants. We're going to put these in so we can get some immediate stabilization, keep that overdenture in, and then we'll come back and add the locators. And these are still good. So she winds up with 4 pillars of support. You know, nowadays I wouldn't do that because I worry about these breaking. And they will lose integration over time. If you have a mini implant that's being overloaded, it's not unusual to see one that's been in function for over 5 years, and all of a sudden they come in. You know, it's kind of tender down there, and next thing you know, it comes right out. You can just wiggle it right out of there. So to me, it's kind of common sense. You know, I used to be a mechanic and a carpenter and all that, and if I got a big piece of pine and I have the option of placing this in it or this, I know that this is going to work better. You know, and so then we just got to get over those cost issues. You know, I don't necessarily charge for 4 implants every time. Sometimes I'll say, look, we're going to charge you for 3. We're going to put in 4. I'm just interested in you getting an optimal result. If we've got 4 and one of them goes south, you still got 3. You know, if you got 2, one of them goes south, you got nothing. So once again, just engineering for the future. This is a case that is similar to one that I showed earlier, where the patient had to lose this canine. Oh, I'm sorry. The patient had to lose the, what was she have to lose? She had to use the lateral. I can't remember. It'll become apparent in a minute. But anyway, gets along with a partial. Didn't want anything fancy, so we're going to go ahead and add this guy right here. And then, once again, pick up impression, process a tooth and acrylic in the office onto this existing partial, then incorporate the locator attachment into there after it's been in function, after it's healed for a while. So what we've got here is not the most aesthetic thing in the world. This lady thinks I'm a genius because all we had to do was 1 implant. She got to keep a partial. You know, you can tell aesthetics is not her #1 concern. It might be finances. It might be a lot of other things, but we were able to take an existing prosthesis and keep it serviceable. So this is a story about Max that I was just telling you about. He got to experience edentulosum firsthand. This is a guy who was wearing a lower denture and started using cushion grip as his own neutral zone technique. He figured out that if he added a bunch of cushion grip all around his denture, that it helped keep the denture in. And he liked having all this bulk on the inside and the outside. So when it came time to make his final prosthesis, we just duplicated what he had made with his existing denture. I just duplicated that, took a pickup impression, sent it to the lab, and asked them to just make it exactly like that. And then we wound up making this bar that you see here. And these are laser welded. There's a mistake because these things wound up wearing out. So we had to cut them off, drill a hole, drill a hole, drill a hole, tap, 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 and then put some locator patterns on there. So these are the originals. They were laser welded here, laser welded there, laser welded here. He never thought it was retentive enough, so we drilled this out, put a locator there, put one there, put one here, put one there, put one there. So now he's got plenty of retention. And that's the beauty of that locator bar system, is you can put the bar, remember I did that with your patient? Put the bar on a drill press, drill the holes, tap them, screw the locators in, and we got to keep this same nice big metal framework. But as I said, these were laser welded, and when these wore out, I think what happened was the lab polished them. And you're only supposed to use glass beads or something like that, and they wound up destroying the retention on the thing. So there's his prosthesis with all that extra bulk on there. In fact, we had to go back and do it over because they forgot to put the lingual part. So we had to go make him another one. And, the guy's happy as a clam. Another case, little hybrid. We don't do a lot of these at all. In fact, I hadn't done one in a while. But screw-in bridge, I know it's all on 4 is kind of the popular thing nowadays with clear choice and all that stuff. I'm just worried about people's ability. I've seen a few cases all on 4 where one of the distal implants is in trouble, and the whole case is teetering on whether or not we can keep that implant long term. So as I showed earlier, I like to break it up into sections. 2 3-unit bridges in the back, 6-unit bridge in the front. So if we have a problem, we can service that area, and it's not going to jeopardize the whole restoration. It's just a little hybrid screwed in place. This is her upper. She didn't mind keeping the palate. Actually, I guess she did. So we took the palate out. Here's a locator bar for the upper. This is old stuff. Some of these cases have been in a good while. These are tightened at 20 Newton centimeters. I got can I say that what you got for me, the electric screwdriver? I can't say that? It's too late. I already said it. Joel got me an electric screwdriver from South Korea. It's a torque wrench. I mean, this thing is fine. And it's too expensive, but I just had to have it. So it's a torque wrench that's electric. It's rechargeable. And you can dial in how much torque you want to have on the screw. You make it go forward, reverse. You control the RPMs. You do the whole 9 yards. And so I said, all right, we finally got it. And I opened the instructions. It's all in Korean. There's no English anywhere in the book. So it's like, well, the universal sign for off-on is this, and the T must mean torque, so we finally figured it out. That thing it's pretty slick. It really is pretty slick. So overdenture, overdenture, overdenture. This is, let me just, that's just a nothing case. I'm looking for something here. Before CTs and all this, we were taking duplicates and using those as surgical guides. We don't really do that anymore. This is a lady who, she's had some stuff done. I mean, she's had these. This was the HA particles that look like a caterpillar that were woven, and they make an incision, insert this thing in, and of course, this just pounds away at it. So it really didn't do much to help with the maxilla. In the bottom, she really didn't like having clasp and all this stuff. So we looked at the idea of placing implants where the first bicuspids are, locator attachments. She got that done. She really liked it. She did bilateral sinus lifts on the upper, tapered screw band implants all the way across the top. You can see the lower prosthesis in place here. Here's a cast bar on the right side with locator attachments, cast bar on the left with locators. Jimmy, you see this panoramic image? This is Tom's Panorex that I got from Tom. If you buy, none of his stuff ever works right. So all of our Panorexes are distorted. Somebody said, "What is this patient have aplastic something or other?" I said, "No, that's a bad Panorex." So here's where she started out, okay, with this lower prosthesis, and she'd been seeing Mike McGinnis in Baton Rouge before, and there's the lower prosthesis snapped into place, no clasp, which is what she really wanted. This is a wax up of the bar section on the upper right, bar section on the upper left. We take a break at 2:30? 2:30, good. Okay. Had this cast up. Of course, I unscrewed these and then had it cast up, get it back from the lab, screw these guys back into place, make our occlusion rim, soft tissue model, and then go through all the steps of making the final palatless overdenture. Real nice result. She does not take care of it worth a damn. I mean, it makes me crazy. And fortunately, she hadn't had any bone loss, But, I mean, the tissue looks awful. She's happy with it. Lab did a nice job.
What is your hygiene protocol for your implantation?
For what?
What is your hygiene protocol for your implantation?
I try to scare him to death. Like if you don't take care of this, you're going to have some discomfort, and you're going to be out of some money, and you're going to be right back to where you wound up, So fear is good. As far as the protocol goes, it kind of depends, It depends on what they're going to do and what they're not going to do. Some people will use superfloss. I find they're maybe in the 5% of the population, maybe. I like the water pick a lot, and I like having them use microcin, which is an antibacterial solution that's not commercially available, but it will be soon. I like it a lot better than Paradex. It kills bugs better than Paradex. It doesn't cause staining, doesn't cause altered taste perception, and it doesn't cause staining, which is the big deal. Because Paradex is great, but my goodness, if you're doing a perio case, like a peri-implant case or peri-pros case, and you have temporaries and then they're using Paradex, it gets ugly quick. And with microcin, we don't get any of that. So I like water pick. I like microcin. I like the Rotodent for some people. The Rotodent is like a little toy. It ought to have more horsepower, and it ought to be more. There ought to be more to it than what you get for $180 or whatever it costs. So along those lines, some of the Rotodent copycats that have come out with rotary brushes. I have some patients with refractory periodontal problems that I have use Hibiclens. And I just tell them it's going to taste awful, but I want you to use it every day. And Hibiclens it's soap. I mean, it's chlorhexidine soap. And it's incredible, how well that stuff works. Before we had microcin, we were using Dakin solution, which is Clorox diluted, and the patients have to prepare it themselves. It tastes awful, but man, it kills bacteria. But microcin, I think, is kind of our go-to thing now. Well, you know, they really see the hygienist every 6 months. You know, I just find a 3-month recall is we don't have room. We just don't have a room for all that. And you know, a lot of those folks, they're not going to come in that often. Now, if they're periodontically compromised, then I need to see them a lot more often. But some of these people, you know, they come in every 4 or 5 years. Everything looks perfect. You know, it's almost like we don't even need to take X-rays, but we do anyway. But some of them are just, it's like, you know, they're at that steady stage where it's like, you know, it's been 5 years, everything looks perfect. You know, I have every reason to believe that we're done, you know, other than the service work. And so the point that I was trying to make earlier about, and you just jogged my memory, about if everybody in the room lost their lower teeth and you had a choice of fixed or removable, everybody in the room wants fixed, but we recommend removable a lot to the patients because it's less expensive. But the thing I've seen is, in my own practice, is that when we do removable, we see those people. I mean, they come back. The denture broke. There's a tooth off the denture. It's not snapping in anymore. We got replacing snaps. And so you know, there's a lot of follow-up, particularly when you extrapolate that over 10 years. When you do removable cases, there's some maintenance involved. And you don't see that with fixed. It's kind of like with fixed. They take care of it. We're pretty much done if they take care of it. And so you start looking at the time allotment in both phases, you know, and it's caused me to bring my fixed fee down because somebody really wants fixed, and I think they're going to take care of it. I really want them to have it. We did an experiment. We took 8 patients that were in removable that I thought might want to have fixed instead. I said, you know what? Here's what I want you to think about this. I want you to think about going into fixed teeth. Here's what it looks like. I'm only going to charge you lab stuff. I'm not going to charge you anything, just the cost of the parts and all that, lab fee and so forth. Oh, yeah, that sounds good. So we convert them over, and then the final deal was, so what do you think? It's like, how come we didn't do this first time around? It's like, well, it's a long story, you know. And 100% of the time it's like, man, this is so much better. I don't have all this bulk in my mouth. You know, it's more comfortable. I can speak easier. You know, I'm not worried about the denture breaking while I'm brushing it and all these kind of things. So as far as the economics go, you know, I find that we need to charge maybe a little bit more for an overdenture, and maybe I'm going to come down on the fixed a little bit. Because if somebody needs a 12-unit fixed bridge on the upper that's implant supported, it ain't going to be $12,000. You know, everybody's $1,000 a unit or $1,200 a unit, or wherever you charge in your community. We're not prepping 12 teeth. I'm not packing cord around 12 teeth. I'm not making temporaries for 12 teeth. I'm not having that insertion appointment, you know, that's demanding sometimes for 12 teeth. And I'm not doing endo on one of those teeth, maybe at no charge, because they develop an acute abscess or some pain or something like that down the road. You prep 12 teeth, you know, statistically, one of them is going to go south, maybe 2, you know, maybe 3. So, you know, kind of philosophically looking at it like, man, there's not a whole lot of labor involved in this fixed deal. And I think the patients would be a lot happier. And it's kind of what I'd want to have done. So because I can afford to nowadays and I think we're efficient, I'm going to drop that fee down. I'm not going to advertise it. Because they got some people that I'm going to charge them double. Because I can tell you, they're going to be a nightmare. But there are other people that you almost feel guilty when you get all done. It's like, man, I feel like I ought to give them some money back. It was so damn easy. And they come in and they bring me chicken and biscuits and, you know, all this stuff. And you almost feel bad. Whereas the other one, that you gave the patient a break, no good deed goes unpunished. I mean, they crucify you. Well, I thought that, you know, I thought they were going to be, it's like, Jesus, you look like hell before. Now you can eat anything you want to. And you're complaining about, when I talk a little bit of air, why don't you take a look at that fat ass of yours in the mirror and do something about that? You know, that thing on your face with hair growing out. Nobody sees that, you know. And the nice thing about having before pictures is I pull those before pictures up and say, you remember this? Remember this? I got a guy that's a state trooper that every time he comes in, he goes, you know, I never have really liked the way this crown and bridge came out. Well, he's got canines in the lateral positions, and it's a nightmare. He's in a car wreck. He lost a bunch of his mandible on the bottom. And he always complains. I said, Mike, look at what you looked like when you came in. You don't want to look at that. He just likes to complain. That's the reason I'm going to retire. I like doing it, but people are wearing me. They're wearing me out. They really are. And y'all too. This is a lady that. We got to take a break, right? Okay, let's take a break.
Without further ado, Dr. Smith.
Right, we're going to wrap it up. We have 1 hour left. And by the time we're done, I think I'll have covered everything that I wanted to today. Somebody asked about the sonic well system. So here's a little bit about what it looks like. Now, like a lot of things, these pictures make it look pretty simplistic. It's a little bit more difficult to deal with than you might imagine. But the idea is you're going to take this polygalactic, it's like an acetate film, and when you run some hot water over it, you can bend it. It molds. And when it comes back to mouth temperature or room temperature, it stiffens up. So what we do is your mic's not on. Oh, it's not on? Okay. Okay, now it is. So what we're doing is we're trying to create a pouch, like you see right here. And once we've drilled a hole here, one up there, then we'll go ahead and hydrate this with warm, almost hot, sterile saline. And then we can kind of mold this thing in the mouth and then bolt it down. And then we'll go ahead and pack all our graft material in there after the implant's been placed, or if we're doing it just as a lateral augmentation procedure, we'll do it without an implant. So this is what you got here. This is before, this is after the little membrane's placed in this area here. This is before. Here's another one. This is what we wind up with. So it's really, it really is predictable. And it really, really works well. It's another case that I showed earlier today. There's the implants, the AnyRidge implants. Here's a case where this is on Joe Tullis. Look at the scan. You see this. This is what it looks like in the cross section. Here's what it looks like after we grafted with sonic weld. And here we are after this area is healed. This is our post-op. Did the same thing on the bottom. Real thin down here. Augmented this area here. There's a close-up of before. And here's a close-up of after. And it's going to look like this in 6 months. It's not like you're going to take another scan and now it's gone, which is what will happen if you put particulate and just put a membrane over it. If you don't have anything to resist that lip pressure, this stuff is just going to melt right away. So there's our post-op of the lower, because he's got like a little bonded tooth, a deciduous tooth in this area right here. There's a close-up of the upper. And so now we want to look at this case. I'm going to see if I can link, if this link's going to even work. And so this guy comes in, and this is what he's got going on. And this looks a little bad on the Panorex. This looks real bad on the Panorex. On the CT, it looks much worse. And so here we're looking at the sagittal cut. So we look in the mouth, and what we see is he's got a bunch of sinus stuff going on up there, a little bit down here. Almost no bone left at all. Mike talked to him about, you can put the implants in at the same time. So no, we can't. Not even close. So when you look at the sinus disease and all this infection, particularly up in this area right here, what we talked about is first we got to take these back teeth out, okay? And this is what you've got going on. This is what you've got going on up here. So all this has to go from here on forward. It's got to go. This has got to go. And so we look at the idea of taking those teeth out, letting those areas heal, coming back and bone grafting both sides, sinus lifts, bilateral. Later on, coming back and putting AnyRidge implants up in this area here, and as well as down here. And this is what the final result is going to be involved in. Malone's going to do all this crown and bridge and this thing down here. Typical Mike, he also crowned everything. So it really came out nice. Another alternative would be to put implants, attachments, maybe a maxillary partial denture, or take everything out, 4 implants in a bar. And so this is how we can kind of get them to understand what our options are. So if we look at this, we see we've got all this sinus disease going on. So we took these teeth out, put some graft in there, and then sent him to the ENT, got all this cleared up, did some sinus lifts after that. I showed you this earlier. This is using the platelet-rich fiber membrane. We're going to go ahead and add our bone graft, pack that down inferiorly, and then fill up the rest of this with platelet-rich fibrin. And then more and more dentists that are just using this and not using any bone graft material at all anymore. So this is interesting stuff. So here now we can see here's what we've got in terms of bone on the upper right side, up in here. And so now we can start planning our implants. And we're going to use AnyRidge implants in this grafted bone. I just think this is a better way to go in terms of getting better primary stability and ultimately a better long-term result. So here we're treatment planning this upper right side. Here's where we are here. And now we're going to start looking at the upper left side. Got a good width and good height now. Same thing here. Same thing here. And so here's what the case looks like. These implants were buried because they're engrafted bone. I just want to make sure that he wasn't getting any pressure on them. We get the single implant on the lower right side. As I said earlier, when we're trying to explain to patients what their options are, there's a website, and if you type in patient animations, it's all one word, .weebly.com, you'll be able to pull up a website that we use to show our patients animations of implants and crown and bridge and all this kind of stuff. And it's like a go-to. We can use an iPad and do a chair side, or we can pull it up on the screen, or they can show in the consult room. So it's like everything is in one place and it's in the cloud. It's not on her hard drive and then that computer broke down. Now we lost information. It's patient animations. Just patient animations, all one word. .weebly, WEEBLY.com. So this is the guy before. This is what he looked like before. You know, and Malone's office put him through a real rigorous oral hygiene program. Got him to quit smoking. In fact, the day I did his implants, he had one of those electronic cigarettes because he was using that to wean himself off the tobacco. So this is what he started off with. You know, just a real train wreck situation. This is after the case is finished on the upper. This is after it's done on the lower. Mike veneered these lower anterior teeth, crown and bridge in the back. Real nice restorative work by Mike Ballerina. When we made these custom abutments, we had each one of these at about a 0.5 millimeter supragingival, because the guy was not one of these going to pull his lip back and look, and that way we've got our cement margins, supragingival, no chance of trapping cement subgingivally. Just a really, really nice result, and Mike's good to work with. So, you know, big night and day difference in terms of this guy's appearance and his ability to function. Any questions about any of that? Just to keep me on track. So we went through the sonic well. Now we're going to talk about a patient who's my brother-in-law's sister. So she came and had a consult and decided she was going to go to the dental school and have her implants done there. So after 40 trips to LSU, and change in residence, and now she's got the new resident, and then this thing's failing, and so the new resident said, well, we're going to make you a lower partial denture, and she stormed out of there and was all nice stuff. They'd done some sinus lifts, grafts, and put these implants in, but none of this had ever been restored. It's going on 4 years. So this is what the case wound up, was what we wound up with, but I'm going to show you how we got there in a minute. But we did add 5 implants to the case. We were able to put these in down here, over here, add one more over here, and get her restored with fixed bridge work. But we did a CT scan on her. This is the scan from the ICAT, which is, we're not using that anymore, but just to get an idea, trying to give her an idea of what we can do, because they told her, we can't do anything else for you. You don't have enough bone. I said, well, Leo, Ann, you know, in the scan, it looks like down here where they removed that implant, this looks pretty good. You know, so we can use this site. And what we know is we've got 9 millimeters of height and 6 millimeters of width. That's not a bad site at all, okay? And so we look at this situation here in the lower first molar area. You know, bone doesn't look quite as good, but we've got 6 millimeters of width and almost 8 millimeters of height in this area here, okay? So we get on to the other side. We have a good implant here, but we're missing this guy. This looks good. So we blow this up. We've got 7 millimeters of width and a good 9 millimeters of height. So that's workable. And then over here, going one back further, we're still good. It's not a lot of bone, but we can work with that. And the question is, why didn't they put an implant here and why didn't they put an implant here? She said sinus lifts. She said no, that they didn't have any fail there. They just didn't put them there. So I said, well, the graph looks good. Why don't we think about adding one right there and adding one right there? And I don't even know what this means. We measured the grafted sinus and Hounsfield units to determine the density, but I don't know if that's good or not. I really don't. I should know, but I don't. Anyway, in this area right here, I said, well, we've got decent bone. We can kind of work with that, and we definitely can work back here. So what we're going to do is we're going to add an implant here and in 4 other locations, including this up here. This looks all right. It's not outstanding, but it'll work. We've got 11 millimeters of width and a good 11 millimeters of height. It's a perfect AnyRidge site, but I wasn't using those implants back then. Looked at the TMJs. The TMJs look good. No issues there. So we've used our planning software to try to figure out where these implants need to go and the spacing and all this fancy stuff, and kind of got it all figured out, made some guides, and just went ahead and executed the case. And I'll show you what it looks like in a minute. So this is a final case. Everything's finished. Made of this German girl in Lafayette, did the crown and bridge. She's really good. But you can see back here where we're lacking. We used some pink porcelain back there. Same thing over here. Nice looking smile. Takes exquisite care of it. She's one of those people that I don't worry, I don't lose any sleep at night because she does what we ask her to do. And that case on the wrong patient could turn into a nightmare. So, how do you size it up? It's kind of it's an educated guessing game. I mean, I hate to deprive some patients that really will do a 180 and get their act together like Mr. Pressenbach did. But at the same time, if you marry the wrong patient and they don't take care of it and they're still going to smoke and they don't, I've had some patients tell me, my depression is so bad that I don't even brush my teeth. And so you think, well, can depression really be that big of a deal? You're damn right it is. My dad used to say it's the common core it's the common cold of mental illness, and that's how common it is. And people that are depressed, they don't take care of themselves the way they need to, and they definitely don't take care of their teeth. So, we're trying to figure out what's going on with people. It's kind of good to know that, because it's common. It's real common. And I've lost a couple friends from suicide, that were depressed. 2 of them are dentists. And so it's a subject that, I take pretty seriously because if they're going to have this work done, I don't want them falling apart emotionally in the middle of the case or getting wrapped up on some aspect of the case, and all of a sudden we're sideways and I can't communicate with them, and they're not going to take care of it, get mad, and go home. And fortunately, I haven't had any of that happen, or if I have, I've forgotten about it already. And that's one of the neat things I think about getting older, is I don't seem to remember that much anymore. It's like a lot of that stuff just kind of fades away, but it's you need to make sure that patients are mentally stable. Patients that are bipolar. I had a lady who, I forgot what her name was, but she told me that she was Robert Kennedy's illegitimate daughter and that she was raised in a convent in Germany, and she was German. But I said, well, you and Robert Kennedy about the same age. He's not alive, but you're like his age. I don't know how you could be his daughter. And this lady, I'm telling you, man, she tormented me. She called my house and talked to me on the phone for an hour once a week. And finally, when we did her case, she thought it was going to be individual teeth and one implant for each tooth. And she got mad and she didn't pay her bill. It's like, psh, I'm done. I never saw her again. But it's like that was a relationship. And I learned a lot about bipolar patients. That when they get in the manic phase, boy, you can't get a word in sideways. And they are terrible dental patients. I mean, they're the absolute worst. So for your own protection, we worry about, well, you're not brushing well and all that. Make sure they're not crazy, because that's a big deal. It really is. And they, I had a lady. Her name is Virginia Causey, and I got a letter from the state board telling me that the case had been dropped. What happened was Virginia hit a cow in Ville Platte. She was driving in Ville Platte. Somebody's cow got out, and she plows into this cow. And then she goes to see a friend of mine that's a lawyer, and so she wants to sue the guy that owns the cow. So let me see what happened here. So anyway, she hits a cow. She wants to sue the guy that owns the cow. Hires a friend of mine, Mark Mouton, as a lawyer. He sends her over to me. I do an exam and said, you got some failing bridge work and decay and all this stuff has nothing to do with the wreck. Well, she was furious, man. She wrote me this letter saying, you're incompetent, I'm going to report you to ADA and all this. It's like, so I write her back this long letter with the x-rays and the arrows and all that stuff. So we're going back and forth because I can't let it go. You know, now I don't care about my principles as much as I used to. This